Well, good morning, everyone. It's great to be back in Eastern North Carolina. Like Sandy, my roots are actually here as well. I was actually born in New Bern. My twin sister and I were. My mother is actually her roots are actually not far from here in a little town called Blackjack. She actually went to a school which I believe used to be known as Shakad, and I think it may now be an elementary school or a community center. So lots of roots here. It's nice to be back home and to also chat with you a little bit about sort of Medicaid reform, sort of nationally and also more specifically sort of what could be in store for North Carolina. So, and also I do have to give you a disclaimer. It is true that I was the former state Medicaid director here, but I am not the current Medicaid director. And so I don't speak on behalf of the governor or the secretary or their Medicaid director, who many of you may know, Dr. Robin Cummings. All good people. So first, these two topics of spending and healthcare quality are really on the top of every state's agenda, whether it's the state Medicaid program or the state legislature. These are two of the biggest issues that all states are grappling with. Of the two, clearly, spending is the most frequently cited among states as the need to reform their Medicaid program. Here in North Carolina, these 3 points that you may be familiar with that the governor and Secretary Vaush have talked about really over the last year about why does North Carolina's Medicaid program need to be reformed, and it comes up to these 3 points. One, they need North Carolina's Medicaid program to be, for its budget to be more predictable, more sustainable. They need the Medicaid program to care for the whole person. Where they're coming at from there is sort of integrating primary care and mental health together and sort of serving that whole person. And then lastly, whatever Medicaid reform path is chosen, their hope is that it would provide sort of greater administrative ease for everyone involved in the program, whether that be the Medicaid recipient, the Medicaid providers, the billers, and all the other folks that sort of support the larger healthcare system. So, recognizing that this is a very diverse group, we've got business people, we have both state as well as local elected officials, and we certainly have a lot of sort of health thought leaders in the room. I thought it may be helpful for a few of you if I sort of step back and talked a little bit about what is Medicaid and sort of specifically what does Medicaid look like in North Carolina. And by the way, I also sort of show where my roots are. My first job out of college, they'd mentioned that I graduated from Mount Olive. I actually went to school, actually taught at Sampson County School. So if there's anyone here who went to Union Elementary School, I apologize if you actually were in my class. But so I tend to sort of roam a little bit. So if you see me sort of step out from the podium, that's sort of why. So what is Medicaid in North Carolina? That again, sort of 101, some basics, that the Medicaid program nationally was actually created by an act of Congress in 1965. North Carolina actually submitted its application, what's called a state plan, to the federal government that lays out how they were going to operate their plan. They did that in the latter part of 1969. It was actually approved, and they actually implemented the Medicaid program as we know it as of January 1st of 1970. It is a joint state federal government responsibility, and as such, it's actually funded by both the federal government and the state government. We'll talk a little bit about that. It is the largest source of funding for medical and health-related expenses for both poor and disabled individuals across the country, and more specifically here in our state. And just to put some numbers, some context to this, as of June of 2013, North Carolina's Medicaid population totaled 1.3 million people. At that time, that was somewhere between probably around 18% of the population. And so who were those 1.3 million people? Roughly 72% of them were children and their parents. And the remaining sort of 28%, 18 were considered what you call duals. These are folks that are dually eligible for Medicare and Medicaid. So what does that mean? That means that someone, as far as Medicare is concerned, has worked enough quarters and has qualified for Medicare, but yet they are still poor enough to actually also qualify for Medicaid. So they actually get benefits of both programs. So that's about 18% of the folks in Medicaid. And then the last 10% are those that have been determined to be age, blind, and disabled. And so if you're curious, thinking about sort of, again, the Medicaid budget, where does most of the money go? The vast majority of the money is actually spent not on the 72% where the vast majority of people in Medicaid, these are the healthy kids and parents, but it's really spent on these last two groups, again, the duals as well as the age blind disabled, and I'll talk a little bit about that a little later on. A little more background for Medicaid, for those of you who may not know, that regardless of what state you may go to, whether it's right here in North Carolina, whether you may drive up the coast to New Jersey or over to Wyoming or into the Northwest into Oregon or Washington State, these same four drivers that I've got up here that drive the cost of the Medicaid program in North Carolina are the same in every state. And they are simply, the first is eligibility. Who is it that you cover in your Medicaid program? The second is benefits. What benefits do you cover under your Medicaid program? So how broad is that umbrella? Thirdly, how much do you pay the people who provide the services on behalf of the people that you cover? So those are the first three drivers. And the last is something that I call utilization, which gets at how frequently somebody actually accesses those services that you actually cover. And you may see a little red box around utilization, and that's just sort of a reminder to me, a reminder to you that the organization that I work for, known as Community Care of North Carolina, and we work with 14 different networks across the state. We have a contract with the State Department of Health and Human Services, more specifically the Medicaid agency, to help them with their recipients. And our contract actually only allows us to influence this block down here called utilization, and we actually only influence about 45% of the total amount of Medicaid's budget. So even though I work for Community Care, it's just important to point out that this is where we have the responsibility with our contract. We have no decision, and nor are we asking for input on who gets covered under North Carolina's Medicaid program, what benefits are provided, or how much providers are paid. Another point about Medicaid is that all Medicaid programs are different in every state. Again, these four drivers that I shared with you are the same in every state, but each state technically looks very differently. The federal law that governs the Medicaid program actually splits the people that are in Medicaid as well as the services that are covered into two different buckets, one called mandatory and the other called optional. And every state has to cover all the mandatory Medicaid people and all the mandatory Medicaid services. And then it's up to the state what of the optional people, optional services are covered. And now to North Carolina, it's our state legislature that actually decides which of the optional people and optional services we're going to cover. The chart I have up here is really just an illustration to kind of drive home how, again, how states vary and how they run their Medicaid programs and how they look differently. What I've got up here is a chart that's titled Optional People Services Covered by North Carolina, covered in our North Carolina Medicaid program. And then off to the right are the states where that particular service or group of people are not covered. The very first one is a group of eligibles called medically needy. For those of you who may be familiar with local departments of social services, there's a group of folks whose income is slightly above the income limit to qualify automatically for Medicaid. So they use their medical debt, whether that's be in a nursing home or hospital bills, to call what's called spend down, to bring their income down to actually qualify for Medicaid. These are generally a group of folks that actually have enormous amounts of medical bills, usually very medically frail. That is a group that we cover under North Carolina's Medicaid program. But if you'll look, states to sort of in our south, sort of our neighboring states, Alabama, Mississippi, and South Carolina, do not cover this group. Another group that we cover in North Carolina's Medicaid program are a group called non-SSI adults. We cover them, but Alabama, Florida, Georgia, Mississippi, and Virginia do not. If you want to talk about a couple of services, and again, these are optional services like adult dental, hearing aids, and private duty nursing, you'll see these are things that we cover under North Carolina's Medicaid program, and you'll see the states that do not cover those services. And then lastly, what is sort of an interesting development over the last year, that two states are now looking to amend their contract with the federal government about how they run their Medicaid program to put a specific hard limit on the number of hospital and ER visits that a Medicaid recipient can access in a given year. And those states are Alabama and Florida. Again, those are restrictions that are in place in those states, but not in North Carolina. So this chart and the previous chart really sort of help explain why I put this last bullet up here, and that is this helps explain why North Carolina's price tag for its Medicaid program looks different from other states. So when you hear folks say, well, why can't North Carolina have a Medicaid price tag, sort of a per capita cost, just like South Carolina? Well, you have to say, well, the two programs aren't alike. We cover people in North Carolina that South Carolina doesn't. We cover services that other states do not. And then lastly, you lay on how much do we actually pay our providers. And I think most people will agree that Medicaid probably does not pay as well as most commercial insurers. And in some ways, we don't pay as well as Medicare rates. So all of that sort of explains why North Carolina's cost per person could be higher than a lot of our neighboring states. And again, it comes back to we have a fairly, what you may call, robust program. We cover nearly all the optional services and all the optional people available to a state under a Medicaid program. So this leads us to, what does all of that potentially cost? And what I've got up here is just to, again, just put this in context. In North Carolina, our budget for the current state fiscal year, and that's the year that ends as of June 30th, 2014, the overall Medicaid budget in North Carolina, that's supporting the staff, the contracts, all the IT, as well as the payments that go out to healthcare providers, is actually $3.1 billion. That's a fairly steep price tag. It is supported predominantly by federal Medicaid money, and you'll see that comes in at about $8.2 billion, or roughly 63%. State appropriations, that's the amount of money that the state legislature appropriates for the Medicaid program, and that amount is $3.5 billion, or 26%. But there's also a line of money that's not federal, it's not state appropriations, but it's just other revenue that comes into the Medicaid budget, and that includes something called drug rebates, it includes bed taxes and fraud recoveries and cost settlements, and that comes up to about $1.4 billion. But what's most important about all of this, even though Medicaid's total budget is just over $13 billion, 92% of that budget is what is sent out to payments to healthcare providers, whether that be dentists and podiatrists or mental health providers or hospitals. That total is roughly 92% of that $13 billion, or $12 billion. So the vast majority of Medicaid's budget is actually sent out to healthcare providers. So, knowing that bit of information, how do we stack up as far as spending, the overall increases in the Medicaid budget year over year? And the reason I put this slide and the next one up is that over the last probably 12 months or so, there's been a lot of folks who've talked about the out-of-control spending of North Carolina's Medicaid budget. It's just sort of growing by leaps and bounds. And what I want to share with you are some facts. And the first of this actual source of data actually comes from the Federal Oversight Agency for Medicaid, known as CMS. And so they collect information. They're behind about 2 or 3 years, but this is the most recent data they had, and sort of showing how North Carolina's, again, looking at that $12 billion payment, the Medicaid claim spending that goes out to providers, how does that stack up in sort of the year-over-year percentage growth to other states? And you'll see this is basically almost a 10-year period. We start with fiscal year 2002 through 11. That's sort of the gold-colored bar. The green is a 5-year slice of that period, and then brown is the most recent slice of 3 years between federal year 2008 through 11. And so we show it, I could have done this for all 50 states, but again, these are sort of our southern states that folks most likely sort of compare North Carolina to. And you'll see North Carolina out on the most left-hand corner, and we are the only state, as you slice this sort of almost 10-year period, where we had a decline in our year-over-year growth in all 3 sort of slices. And in fact, the last little brown bar indicates that our rate of growth is actually about 2.3% in that last period of time. In more recent data, it appears that it's actually dropped below 2%. So when you look at other states, and these are their same Medicaid programs, so we're doing sort of an apples-to-apples comparison, you'll see Alabama and Mississippi, basically all of them have sort of an upwards trajectory. None of them have sort of sustained decreases in the overall year-over-year cost of the program, like North Carolina. And what's interesting too, if you look from Florida over to Virginia, these are all states that have basically turned over whole or parts of their Medicaid program to commercial managed care companies. And so that provides you sort of an extra comparison of, since we don't have commercial managed care in North Carolina's Medicaid program at this time, what do we look like in states that actually do? So that's one comparison. The last set of data, it actually gets pulled from the state budget officers. So this is data that gets submitted every year. So our current state budget officer, Mr. Art Pope, actually submitted this information probably in September, October of last year. This was published just before Thanksgiving of 2013. And again, it's available for all 50 states. You can actually go on the National Association of State Budget Officers website and get this. But I pulled North Carolina again, and pulled also Virginia and Florida from the previous slide, but I added a new state in, and I'll tell you why in a minute. But what this slide tells you, there's 2 data points. You'll see a solid line, which is the overall year-over-year growth in the state budget. That is everything under the state's umbrella. That includes health and human services. It includes corrections. It includes environment and natural resources. It includes everything dealing with education. That shows you the year-over-year growth compared back to 2007. The dotted line is the same number, but just for Medicaid. And so if you look at these lines of growth, North Carolina, particularly of these 4 states, is the only one where its Medicaid program's growth year over year was actually under the growth in the overall statewide budget. In Virginia and Florida, and certainly in Arizona, that pattern was actually reversed. And what's most notable about Arizona, because they've actually had a 75% growth in Medicaid since 2007. We had 10, Virginia had 40, and Florida has had 34. What's notable about Arizona is that they, when they came onto the Medicaid program, they immediately went into commercial managed care. So they've always been under a sort of commercial managed care Medicaid program. And you'll see here that they have a dotted line where the costs go up, they kind of come back down, they go back up, and they come back down. Those sort of peaks and valleys correspond when that state Medicaid program was renegotiating its managed care contract. So they negotiate slightly lower cost, costs go back up, they renegotiate their next contract, costs go back down. You don't yet see that same sort of phenomenon in Virginia and Florida because both of them are ramping up their managed care, but my guess is 3 or 4 years out, you'll probably see a pattern much more similar to Arizona. So that's cost. And what basically this chart and the other chart tells us is that even though North Carolina has a $13 billion price tag, it has been growing at a relatively low rate year over year. So what's going on nationally? So now we sort of leave North Carolina and talk a little bit about what other state Medicaid programs are thinking about as they think about reforming their Medicaid programs. And basically, what I share here, these are 3 buckets. That Medicaid reform across the United States really kind of falls into 3 categories. Either states are moving more into commercial managed care, called third-party managed care. They're thinking about what can we do to reform the current payment. You heard Sandy talk about, you know, lots of folks trying to move away from fee-for-service into some other kind of payment environment. And then the last bucket is sort of the newest bucket in town, which is called accountable care organizations, or ACOs for short. So what's going on? This first slide talks strictly about state Medicaid programs that have turned over part or all of their Medicaid population, the management of it, to a commercial managed care. And there's no denying what the pattern is here. The states in red are those states that have some level of managed care presence in their state as far as running their Medicaid program. Clearly, the overwhelming majority of states are moving in that direction. The states that are colored in white, North Carolina, Alabama, Arkansas, Oklahoma, others, currently have no managed care. The yellow are 3 states I'm going to talk about in a few minutes that are moving more toward an accountable care-like organization. But as you look at this map, clearly, and if we had time-lapsed this over the last 5 or 6 years, you would have seen more and more states sort of go red as far as bringing in commercial managed care. What's not shown in this slide is the fact that even though you may have a presence, what is the percentage presence? I mean, what is the penetration? And on the whole, probably, if you added up all of those states, probably 30 or 40% of their Medicaid population is in commercial managed care. So not, even though they may have a managed care presence, it's not the entire population. But the trend is now managed care companies are looking more towards serving not just the healthy kids and healthy parents, but looking more into serving the age blind, disabled, that sicker, more frail population. So that's one trend that states are looking at, certainly moving more of their program, turning it over to a commercial managed care setting. The other is payment reform, and this sort of encompasses a wide variety of activities. One is bundled payments. I think Minnesota was our first state in the country that actually piloted or actually put a bundled payment out there. Arkansas is probably the one that's most notable now. And what they have done is they've developed a sort of a multi-payer initiative which includes not only Medicaid and Medicare, so you've got the two big federal funding sources, but also the commercial insurers have also agreed to participate in this bundled payment. And for those of you who may not be familiar with that bundled payment, it basically, what Arkansas did was they sort of stepped back and looked at their Medicaid budget and said, how much do we spend in a year? Sort of their comparison to our $12 billion. And said, if we had to identify perhaps 2, 3, 4 dozen conditions that consume about a half or 50% of our budget, what would those be? And so they identified them, whether they be congestive heart failure, upper respiratory infection, hip and knee replacement, and they developed a bundle by asking all the providers who are associated with that given condition to agree to come together. They still get their fee-for-service payment in the interim, but agree to come together to better coordinate the care for that particular Medicaid recipient. And at the end, they add up all those payments and they say, did you come in under what we normally would have paid under a fee-for-service environment? So that, in essence, is sort of how their bundle payment has worked. They're starting now with, I think they've got 5 underway. Their hopes is to actually branch out to have at least 3 or 4 dozen bundles over the next 3 or 4 or 5 years. Another thing that's growing in attention is around the talk around never and avoidable events. All Medicaid programs have to follow Medicare's decision that there's certain never events that they don't pay for. So Medicaid follows suit with Medicare. But there are, at least in some states, Texas, for example, has identified some additional, what they call potentially preventable complications and potentially preventable readmissions. And for those conditions and readmissions, they pay nothing. The Medicaid program to those participating hospitals. Another example of sort of never and avoidable events, we have a number of states, and I've identified a few, Wisconsin, South Carolina, and some others that have adopted zero pay policies that are specific to elective non-emergent deliveries that are before 39 weeks. So again, this is an example where a state Medicaid program has said, for this particular situation, we will not pay anything, in hopes that what they will be doing is actually seeing a decline in elective non-emergent deliveries at 38 weeks or earlier. Another growing area of interest in states is around P4P, which is a sort of shorthand for pay for performance, as well as value-based payments. And again, this really comes back to the whole discussion about state Medicaid programs and other health payers wanting to move away from the current fee-for-service model. That's how most healthcare is paid, certainly in North Carolina's Medicaid program, and move to a new reimbursement methodology that recognizes and rewards performance and quality. Some states that are particularly moving heavy in this area are Connecticut, Massachusetts, and our neighbor to the south, South Carolina, that have revisited what's offered under their Medicaid umbrella to identify those services that are greater or lesser value, and trying to also take into account co-payments, having higher co-payments for services that may not have the highest value. Each of those states are working with a nonprofit called the Catalyst for Payment Reform to work on each of those endeavors. And lastly, in this last category called Other, I identified 2 things that are underway, one in Rhode Island, one in New York. Rhode Island, some of you may be aware, actually got a 5-year sort of block grant from the federal government, giving them a set amount of money that they were going to have to operate their Medicaid program for 5 years. And in return, they got a lot more flexibility about how they got to run and operate their program. And that's, if it has not already, it's coming close to needing to either be renewed or to be canceled. But in New York State, they've adopted something called a global budget cap. They were sort of in the same situation with North Carolina year after year of shortfalls in the Medicaid budget and what to do. And so its state legislature decided to empower its secretary, it would be the comparable of our Secretary of Health and Human Services here, with the ability to sort of pull any sort of quiver out of her arsenal or his arsenal to either reduce payments, to tweak clinical policy, to do whatever was necessary to keep the Medicaid budget, that's in New York State, under control. They've been under this global budget cap now for 3 years. They have a same 2-year budget cycle like our legislature. They ended the first 2 years without ever having to hit the cap, so things came in actually under budget. So that is one area that one state has done something fairly aggressive to rein in control over their Medicaid program. Arkansas, just before we leave that, in case you're wanting to know a little bit more about the 5 bundles that are out there right now, they are the total hip and knee replacement, perinatal for non-ICU, ambulatory upper respiratory infection, congestive heart failure, hospital admission, and also attention deficit hyperactivity disorder. So these are the 5 that Arkansas began with. You'll see the duration of the bundle. Those bundles could be 30 days, it could be 60 days, it could be out to a year in time. And then you'll see what they call the principal accountable provider. It's sort of the coach for that team of providers who are agreeing to work together and who they are. So lastly, what is going on in the world of ACOs, accountable care organizations? That's a fairly new sort of entrant in the world of healthcare. Really came about through around the time of the Accountable Care Act. And the first accountable care organizations actually were in Medicare. And so what I've got up here actually is a chart that's specific to where Medicaid ACOs are actually forming around the country. And you'll see there's actually not very many around the country yet, and only those in green, which are Oregon, Colorado, and I believe Minnesota, are the only 3 of roughly 12 that actually have an active ACO underway. They may not have a lot of years of experience behind them, but they are the 3 that are up and operational. What we have found, at least in my work back in the days at the Milbank Memorial Fund and more recently at Community Care, is that these accountable care organizations for Medicaid generally fall into 3 areas. One is a provider-driven ACO, which is more closely aligned with what Minnesota is doing and also what Maine, Massachusetts, and Vermont are looking at. An MCO-driven accountable care organization, which is really what is going on in Oregon with what they call their CCOs. And then lastly, these regional community partnership ACOs, which is specific to what is up and coming in Colorado, and also what they're considering to put into place in New Jersey. What's interesting about New Jersey, some of you may be familiar with Jeff Branner's work around what he calls frequent flyers, sort of looking at your Medicaid program and trying to identify that top 2 or 3% of people who are frequent visitors to your hospitals and your ERs who consume a large chunk of your Medicaid budget, hence the term sort of frequent flyers. Their ACO program is designed specifically at targeting those high-cost, potentially highly impactable patients in New Jersey. So what have we learned, sort of the early lessons of these MCOs? There's lots of experience around the MCOs that we talked about earlier and some about payment reform. But because ACOs are so new, I thought it would be helpful to kind of share with you, just from my perspective, what are some of the early lessons that we have gleaned from other states. And one is a foundation of a primary care medical home is really essential if you're going to move in this direction. What's also equally important is that you have really good data and good analytics about what are going on. Also clearly important is the ability to stitch together primary care and mental health. Because what we hear from primary care docs all around the state, and I heard it when I was at the Milbank Memorial Fund from outside the U.S., both in the U.S. and outside the U.S., is so much of mental health treatment intersects at the primary care visit. We also know what's also important is that states that had a foundation or early experience in payment reform had a better chances of success at an ACO model, and also having a centralized structure. This was something we pulled directly from the folks in Oregon, that need for a centralized structure to get at consistency and uniformity across the healthcare system. And lastly, but perhaps even more importantly, is that ACOs take time to develop. They're also expensive to stand up. We also know that from our experience in looking at Medicare and also these early experience states in Medicaid, that it's unusual to see a state require upside and downside risk in the first year. That's asking a group of providers who come together that if you save money, you get to share in a portion of those savings. But the downside means if you come in over budget, you actually have to pay a portion of that back to the state. So the unusual part of that is asking providers early on, particularly from the beginning, to share in any losses. And then lastly, what we have seen, particularly in Medicaid's experience, is that it is more common for ACOs to carve in services than to carve out services over time. So early lessons learned. So back in North Carolina, what could be, what are we facing? Well, we know that the governor and the secretary have pulled together a fairly comprehensive Medicaid reform plan. It falls into, their recommendations sort of fall into 3 categories. First is that fiscal health will be coordinated through these accountable care organizations, and that the first accountable care organization needs to be up and standing, up and operational almost a year from now, in July of 2015. They are calling for both upside and downside risk from the very start and the level of accountability, both in sharing of savings and in sharing of losses rises over time. And that their hope is 3 years out is that you'll have 80% of the Medicaid population connected to an accountable care organization. The second sort of category of their reform plan is enhancing our current mental health system. And that's one of their objectives is to consolidate down to 4 strong local management entities, LME or MCOs, to strengthen their performance measures, including asking those folks to also have financial penalties if they don't meet certain performance measures, and then also calling upon them to integrate what they do with the local accountable care organizations. And then the last category of the governor and the secretary's recommendations is to strengthen our long-term services and support system. That's the care that we provide to our age, blind, and disabled population, and to ultimately shape the direction of that policy. I think this was more of a nod to sort of recognizing that we have sort of a fragmented long-term care system, and also recognizing that our baby boomers, the first sort of wave of them, are now getting to the point that they are in their 60s and eventually will be accessing long-term care services, and sort of recognizing, some states call that or refer to it as a tsunami effect, that a large chunk of your population over the next 20 years will be falling and hitting into these long-term care services. So what support systems do you have in place for that? So certainly kudos to the Secretary and Governor for recognizing that. So what should we bear in mind in North Carolina as folks start thinking about healthcare reform more locally here in Eastern North Carolina or statewide? And one of the things we thought it's important to sort of first recognize are your assets. And a little bit of a publicity for CommuniCare, the agency that I work for, we believe this is a big asset to the state. There are 14 independent networks that sort of span from Manteo to Murphy. But another key asset, of course, are our big hospital systems, that where a lot of care is actually provided. And you'll see the presence of Vidant, Mission, Novant, New Hanover. These are the big sort of hospital systems and geographically sort of where they're located. So what we did, and this is very sort of preliminary work, again, thinking about the Medicaid population, 1.3 million people, CommuniCare probably serves about 80% of those, so we don't serve the entire Medicaid population, sort of providing them a medical home. We thought it would be interesting to go and look at each of those Medicaid recipients and identify where's their primary care home at? Is it with an independent onesie and twosie doctor? Is it with a hospital-owned practice? Is it with one of the major hospital systems? Or do they get their care through the local health department or through a federally qualified health clinic? Where's their primary care given? So this next chart actually identifies that. And again, this is just the Medicaid population. And again, because some folks, we were not actually able to determine who their primary care doc, this data is again a little bit incomplete and still preliminary. So, and you'll notice that we do these by color. So the first is, these are large health systems. So these would be the Vidants of the world, the Wake Meds, the Dukes, the Carolinas. And of course they have sort of satellite offices that are affiliated with them. So these are where Medicaid recipients have as their medical home. So you'll see how that's sort of dispersed around the state. The next layer we add are other hospital-owned. So these are not large hospitals, but the other hospital-owned practices, and you'll see those. And then you layer on all the independent practices that are not hospital-owned, certainly not owned by a large health system. Another layer to this is you add in our federally qualified healthcare centers, and you'll see where they are. And the bubbles, again, the size of the bubble is the size of their sort of Medicaid caseload. Another layer to add is another vital safety net partner, our local health departments and rural health centers, and you'll see where they fall in. And then the last is, even though Medicaid does not have any ACOs yet in the state, there are Medicare ACOs, and they are basically in Wilmington. I believe you have an ACO over in New Bern. They're Cornerstone, and there's one other, and the dots that sort of orbit it are those doctors that have agreed to come together and serve in those ACOs. So that is where our Medicaid recipients get their care, and so that kind of fills in most of the state, except for a lot of Eastern North Carolina. Another sort of, this is sort of, again, sort of what we call a planetary sort of chart, just to identify that, so where do Medicaid recipients, where do they get their primary care? Clearly, the vast majority, and it's about 65%, actually get their care through an independent practice. And you'll see sort of the smaller where the rest of the folks get their care. Some more preliminary data was that when we looked at where folks actually got their care, we thought it was interesting to sort of look at practices. These are practices that see Medicaid recipients about what's the size of their Medicaid caseload. And you'll see the pie chart, those that have fewer than 50 Medicaid recipients, 50 to 99, 100 to 199, 200 to 499. And then lastly, those that have big Medicaid caseloads of 500 or more, and a lot of those are your pediatric practices. So we know that the vast majority of practices based upon our sort of preliminary data really are practices that have fewer than 500 Medicaid patients. What was also interesting was a second point that we found, that it was really the smaller practices, those that had fewer than, again, 500 patients, that actually had the sickest Medicaid recipients. And so we added this little chart to show that. And this is sort of looking at a case mix index, sort of the higher the number, the more frail, more sick the individual. And you'll see for the practices that have fewer than 50 Medicaid recipients in their entire panel, that they actually probably have the sicker, more frail individuals. And that goes down as, again, the size of the Medicaid panel goes up. And again, we believe that the 500 or more are probably pediatric practices. So that's an interesting fact. Something else we think is important to consider as you think ahead for Medicaid reform is how, again, and this is going back to this preliminary data where we had these bubbles about where people get their care. If you go back, think about, well, it's not going to let me go back. There. So the array of where people Medicaid recipients get their care. This next chart, sort of, and there's three of these, this looks at total spending in the Medicaid program, both acute care, long-term care, everything in between, broken up by those same groups of federally qualified health clinics, the independent practices, large hospital-owned, local health departments, rural health clinics, other hospital-owned, the ACOs, and then sort of a comparison of community care about how total spending sort of stacks up. And you'll see the dotted black line, that's community care. Anything down in the green is better. Anything that's going higher is worse. So you'll see how those folks sort of stack up. And again, this is a preliminary sort of run at this. We also looked at it for emergency department visit rates. And again, you'll see the dotted line a little more clearly about where community care kind of comes in. And you'll see that our independent docs, and also, again, for these small handful of provider-led ACOs, that they certainly are performing even better than the average for community care. And then the last is looking at inpatient admission rates. Again, you'll see the dotted line, which is the average for the 14 community care networks. And you'll see that our independent docs, and also, again, the same is true for the small handful of provider-led ACOs, that their admission rates are actually lower. Again, some food for thought as folks look at sort of what does our health system look like, how does it currently operate, what are the outcomes look like right now, and where do we want it to go. Another interesting graphic that some folks in the office pulled together, and it looks at sort of cross-system traffic just for the folks that we serve in community care. The bubble size, again, represents the number of inpatient admissions by a patient enrolled in that practice. So this would be Medicaid recipients whose primary medical home is with a physician that's owned by Carolinas or Novant or Wake Forest, UNC, Duke, we see Vidant, also First Health, and also Wake Med. So the bigger the bubble, the larger their sort of slice of the Medicaid population. But the interesting thing is the second bullet, which is the thickness of the lines leaving that hospital represent the number of outpatient admissions that occur outside of that hospital system. So for Carolinas, you'll see, again, the orange down here, a big chunk of the Medicaid population served by their physician-owned practices, but a huge number of their patients leave and are seen by Novant, seen over in Mission, and in other sort of hospital settings. And basically their lines actually go over to Duke, to UNC. They actually have patients seen over at Wake Med as well as First Health. So something to keep in mind, again, as you think about the healthcare system, referral practices, where do people actually get their care? So another chart that we pulled together, and this one looks at, or basically summarizes, that a vast majority of inpatient visits at any hospital are patients who are generally probably not enrolled with that hospital-owned practice. And again, in orange are the folks that are a member of that hospital's medical home. Sort of they are seen by a practice that is part of that hospital system. And you'll see that is a tiny, tiny percentage compared to those that are enrolled in another practice that's not part of the hospital or not enrolled with any primary care practice whatsoever. So again, more food for thought. So leads me to sort of my final slides, which are really getting at what's going to happen now. The legislature is now engaged. They have convened their short session. What's going to happen? And I don't have a crystal ball for you today, but I do think these are, what happens is really going to be determined by, will Medicaid's shortfall for the year change? It was upwards to about 150. I believe last week they lowered that number to well below 100. It may be in the neighborhood of perhaps 65 or 75 million now. If that changes, does that sort of create a new sense of urgency among your state representatives and senators? Also, I think an influencing factor will be, what is the appetite within the legislature to take on a really big, meaty policy topic? And then lastly, is there a desire to end the session really quickly? Generally, they're in town for about 6 to 7 weeks. And so if you take on any big policy issue that requires a lot of debate, a lot of thought, that could take that session out further. So what are some possible outcomes? And some of these are less likely than others. Will the governor's Medicaid reform package get through as is? I don't know. Or will there be a call for further study, perhaps calling for a blue ribbon commission to come in and sort of look at and add to what the governor's plan has already sort of pulled together? Will there be any talk about payment reform, sort of moving Medicaid's current fee-for-service system, moving into some of those other things, other ways that states are now paying, perhaps bundle payments, perhaps more never events, perhaps looking at pay performance or payment for value, pulling that into North Carolina's Medicaid program? Will there be an appetite for identifying perhaps a small handful of cost-saving initiatives in this legislative? Or ultimately, will they punt to the next session when they're in town from January through July and have more time to sort of devote to this topic? So those are possible outcomes. So I thank you, and I don't know if you have any questions for me. I'm happy to entertain them or go over any of the slides, or if you have some basics about Medicaid versus Medicare that I may be able to help share with you.
Do you have any perspective about cash flow trends across the nation? I asked the question from the standpoint of being a pharmacist for more than 50 years. And I remember a situation several years ago in the state of Illinois where a pharmacy refused a prescription for naproxen, which was then available only as the brand, because the state of Illinois was taking 6 months to pay the Medicaid prescriptions. And he figured the money that he would put into 100 naproxen tablets, he could buy thousands of hydrochlorothiazide ACTZ for the same amount of dollars and generate more fees through more prescriptions and through that type of mathematics just to stay alive and just to stay in business. It's very tragic to be put into that kind of crossfire when you want to help your people, just because they're human beings and they need help and you can't help. But you can't go out of business in the process of trying to help them. So I think one of the big issues today, no matter which way you cut the narrative, is the basic question of cash flow. People can live with a little bit smaller margins if cash flows are weak or prompt and livable, but certainly not as in the case of Illinois with naproxen years ago, where it took 6 months to pay for one prescription.
Your point is well taken. I don't have any specific information about other states and cash flow. For North Carolina, I think there are two things going on here. One is hopefully much more improved, but the first really deals with reimbursement. How much do we actually pay our provider community? When I was in Medicaid, I think we paid a little more robustly, but since I left Medicaid in 2007, everyone, including North Carolina, has gone through the Great Recession. So there's been sort of a clamping down of Medicaid reimbursement. And that ultimately has an impact on access. You know, can you still afford to see a Medicaid recipient for this reduced reimbursement rate? What is more specific to North Carolina has been sort of the challenges in the early days of the NC track system. That's their new Medicaid claim system. I believe many of those big bugs that we heard about last July when it first came on board, many of them have been addressed, but one of the things that that I read about in the press pretty frequently was that providers were not getting paid. And we know that there's still some isolated problems with providers not getting paid now, but you hit at a balance. I mean, it's one thing if you reduce my rates, but if you don't pay me timely, that's a double whammy that makes it almost untenable for providers to stay in the Medicaid program. So I know those are issues that are important to any secretary, including the current administration, of trying to find that right balance. Yes, ma'am.
What about the problem of the people who have no coverage whatsoever and can't afford it? That's a whole huge part of the population that affects cash flow and coverage and access to health care. What do we do with those?
And for those of you who may not have heard the question, so what do we do about the uninsured, those who don't have access to Medicare, commercial insurance, or even Medicaid? And probably one of the folks that will probably be hit the hardest and the worst are your hospital systems. Hospitals relied upon for a number of years, various funding streams to sort of be whole when it came to Medicaid. And another funding stream they relied upon is something called DSH, the Disproportionate Share Hospital Payments, which help a hospital address the cost related to those who are uninsured or underinsured. That payment stream is now ending. It's now sort of being ramped down with the expectation that Congress had that as they ramp down that DSH program that was payments to the hospitals, that states would then start expanding their Medicaid program to cover the uninsured. And that was a political decision that our state made on the second half of that, not to do that at this time. But that does not mean that care does not go away. It doesn't mean that those hospital costs all of a sudden miraculously get smaller. I don't think that happens. But I think ultimately, that question will have to be raised again about what do we do?
We have a question off of Twitter today. Which Medicaid plan permits physicians to serve their patients best? Our docs care about their patients, it says here on Twitter.
And I'll assume that the question, they want to know which of the three sort of payment reforms, or perhaps whether it's an ACO or an MCO. Maybe I'll take it from both sides. That assuming that the writer was asking about of a ACO approach, which is the Accountable Care Organization approach, or moving more into commercial managed care like other states have done. My personal feeling would be, and my organization has come out and stating that they believe that the governor's plan, the secretary's plan about moving more care into the hands of accountable care organizations is directionally right. It keeps care down at the level of where, and accountability down at the provider level. And so I would say that is probably the best approach.
Thank you.
Any other questions? All right, well, I thank you for your time. It's good to be back in Eastern North Carolina. You've got some really smart people around the room. I know you'll do some great things this afternoon. I'm sorry I won't be with you. I've got to actually head back to Raleigh. But I wish you all well. And again, thank you for the invitation, and look forward to seeing you all again.